heart function can be divided into systolic function, where the heart contracts and pumps blood throughout, through the pulmonic and the aortic valve. So, when the heart contracts and force blood through those valves. So that, in a nutshell, is systolic function. But the heart has to fill with blood. And if the heart is not filled with blood sufficiently, then it can pump a reasonable amount of blood out. So we talk about a systolic function and a diastolic function. And what we have realized is that when you evaluate patients who have heart failure, there's about an equal proportion of them that's going to have systolic dysfunction and diastolic dysfunction. But if you look closely at diastolic dysfunction, what you realize that as one gets older, the proportion of patients with diastolic dysfunction causing heart failure increases. So it's a disease of aging, then, if you want to call it that. So before we talk about diastolic dysfunction, you have to know a little bit about diastolic function. So what is diastolic function? So, in a very simplistic approach would be, say, when the heart fills with blood in diastole. Okay? So systole, we know, is when the heart contracts and forces blood through the pulmonic and the aortic valve. But, it's a little bit, if you sit down and you work out the different components in systolic and diastolic function, then you realize that things can go wrong at multiple levels. So when we talk about diastolic function, so remember, at the end of systole, when the aortic and the pulmonic valve close, okay, that determines the end of systole. At the end of systole, the aortic and the pulmonic valve close. But before the mitral and the tricuspid valve opens, remember that little period of time, that's what we call the IVRT. So that's a part of the diastolic function, because systole was completed, systole is finished, and now you're going into diastole. But there's that first portion of diastolic function we call IVRT, isovolumic relaxation time. So that's a period of time when the aortic valve is closed at the end of systole, but the mitral valve is not yet open. And that period of time, that IVRT, in a normal individual, that's up to about 100 milliseconds. So it's about 60 to 100 milliseconds. So if it's longer than 100 milliseconds, it suggests that there is problem. If it's shorter than 60 milliseconds, that also suggests that there is problem. So at the end of your IVRT, I'll say all the valves are closed, then the mitral valve and the tricuspid valve opens. Because there is a pressure difference, as soon as the valve opens, then there is a rapid suction of blood. Let's just stick to the left side, but the same thing happens on the right side. As soon as the mitral valve opens, there is a suction of blood from the left atrium across the mitral valve into the left ventricle. And that will give us what we call, or so-called, E velocity. Okay? So it should have a normal velocity, and that can vary, The E velocity tends to get a little less as one age, but the actual value can vary with health. So after there's a suction of blood, after there is suction of blood from the left atrium across the mitral valve into the left ventricle, then you get a rapid equalization of the pressure. And when you have this equalization of pressure between the left ventricle and left atrium, you have cessation of blood flow. So you get what we call a diastasis. Now, this diastasis may or may not be evident in individual patients. Sometimes it's there, sometimes it's not there. But you get this rapid equalization of pressure. And then after the diastasis period, then the atrium contracts. The left atrium contracts and pump an additional amount of blood across the mitral valve into the left ventricle, given what we call, or so-called, A velocity. Okay? So in health, in a young, healthy individual, the E velocity is usually greater than the A velocity. Okay? However, in disease state, and if you're developing problem with your diastolic function, the A velocity may become more prominent. So those are the components of diastole. So diastole starts with your IVRT, then you have your E velocity, your diastasis, and your A velocity. So let's just look at our diastolic. So in order to determine what your diastolic function is, you have to look at your mitral inflow. So what I've just described to you is the mitral inflow: IVRT, E velocity, diastasis, A velocity. That's your mitral inflow. You have to also look at the mitral annular velocity, and this is what we call tissue Doppler imaging. Okay, tissue Doppler imaging, because the rationale here is that if you have diastolic dysfunction, okay, if you are okay, well, in health, if you look at your mitral annular plane in a normal young healthy individual, that mitral annular plane in systole it moves up, and diastole it moves down. So if you look at it, it's constantly moving up and down, up and down, up and down. So that's very important, because one of the earliest problem with diastolic dysfunction, that up and down movement of the mitral annular plane is going to be affected. Okay? And we think diastolic dysfunction is really a muscle disease. So in a nutshell, diastolic dysfunction is a muscle disease. Okay, it suggests that there's a problem with the myocardium. And one of the earliest abnormality is your tissue Doppler imaging. Your so-called E prime velocity is going to be affected. In the Doppler session, we look at tissue Doppler imaging, and I told you that when the septum moves up, okay, when the septum or the mitral annular plane moves up, that's what we call our S prime velocity. And it's supposed to travel at a certain speed, okay? And then when in diastole, your mitral annular plane moves downward, and you have an early diastolic velocity we call E prime, and a late diastolic velocity we call our A prime. So the velocity or the speed at which this angular plane is moving is important, because if you have muscle disease, it's not going to move as fast. Okay, and diastolic dysfunction is a muscle disease. So to fully characterize or to look at diastolic function properly, you have to look at mitral inflow, mitral annular velocity, which is tissue Doppler imaging. You have to look at the pulmonary vein flow, and then you can grade, if there's abnormality, you can grade the diastolic dysfunction. Also, left atrial volume. So we went over the how to assess left atrial volume a few sessions ago, and that's very important, because, as you said, diastolic dysfunction is a muscle disease. If you want to look at it as if the muscle does not relax properly. In the early stage of diastolic dysfunction, the muscle does not relax properly. And then as diastolic dysfunction progresses, you have a problem with compliance. So just think about it. If the muscle, the left ventricle does not relax properly, it's going to put pressure on the left atrium, which is a thin wall cavity. So that's going to balloon. That's going to get large. So the worse the stage of the diastolic dysfunction, the left atrium is going to get larger and larger and larger. So that is the rationale for looking at left atrial volume. So if you look at all these things, you can determine if diastolic dysfunction is present, and then not only that, you can grade it. So when we say diastolic function, that's, diastole is the period of the cardiac cycle when the heart is being filled with blood. But you can further break it down into what we call your IVRT, E velocity, diastasis, A velocity. Okay? But if you want to use a very simple definition, it is the period of a cardiac cycle when the heart is being filled with blood. Okay, so this is a Wiggers diagram, and those of you who are doing exams, they love the Wiggers diagram. So it basically combines a lot of stuff. Okay, so this is your phonocardiogram. So this is what you would listen to. Okay, you have S1. S1 denotes the closure of the mitral valve, and S2 denotes closure of the aortic valve. So after the mitral valve is closed, then you're going into systole. And then when the aortic valve closed, that's the end of systole. So when you listen and you hear S1 and then you hear S2, that period of time is systole. And then from S2 to S1 again is diastole. You realize that the diastolic period is a little bit longer than the systolic period. But as the heart rate picks up and the heart rate gets a little bit faster, the diastolic component gets shorter and shorter. Okay, so the reason for that, well, what that can do, patients who have diastolic dysfunction or mitral stenosis, they tolerate tachycardia poorly, because someone with diastolic dysfunction, diastole is compromised, and if you increase the heart rate, then you're going to compromise the period that the heart is being filled again. So tachycardia, so patients with diastolic dysfunction tolerates tachycardia poorly, because you're going to get decreased diastolic filling with tachycardia. So anyway, so diastole is from S2 to S1. And if the patients have heart failure, you'll hear a S3. If they have, hypertension, a poorly compliant ventricle, you can hear a S4. So this is your phonocardiogram, what you listen to. And you can map it up to your your ECG, EKG, because remember we've been stressing that systole is from the onset of the QRS to the end of the T wave, which corresponds to your phonocardiogram, and then diastole is from the end of the T wave to the beginning of the QRS. Okay, so that's your ECG. This is your ventricular volume. So the volume of blood in the ventricle. So in systole, the blood is going to be pumped out of the left ventricle. Blood is going to be pumped out of the left ventricle. So if you start to say 130 mLs, at the end of systole, you'll probably, you'll get a volume, which we will call the end systolic volume, because you're going to have blood being pumped out with so-called stroke volume. Okay, the volume of blood pumped out of the heart per beat. So the volume, the ventricular volume decrease in systole, and then of course it fills up in diastole. Okay, and then up top you have the bright blue line is your left ventricular pressure. So the ventricular pressure. It's the same thing on the right side. So in systole, when the heart contracts, it generates a tremendous pressure, okay? And then as it relaxes, then the pressure comes down. In diastole, the pressure, the mitral valve opens, the left ventricle is being filled with blood. So the pressure is relatively low until systole again when the heart contracts. And the aortic pressure is similar to your LV pressure, okay? The only difference is that you have a diastolic pressure. So whereas in diastole, the LV relaxes and the pressure is very low, because for a normal heart, the filling pressure should be low. Okay, so the diastolic pressure in the LV is relatively low, but if your systole, if you're looking at your aortic pressure, when you check the blood pressure, you get a systolic pressure and you get a diastolic pressure, and your diastolic pressure is not zero or not close to zero. It shouldn't be, okay, because there's still a pressure in diastole in the aorta. Oh, you know that? Okay, there's still a pressure there. Okay, so you have this so-called LV pressure, your aortic pressure, and then the atrial pressure. Okay, so throughout the cardiac cycle, there's pressure in the atrium, and we divide. If you look closely at the arterial, say if on the right side, we usually look at what we call we can look at the right atrial pressure or the jugular venous pressure. On the left side, we look at the left atrial pressure, or the surrogate. The surrogate for that is what we call the pulmonary wedge pressure. But in diastole, towards the end of diastole, when the atrium contracts, there's a little increase in the pressure, and then the pressure falls, and then there's in systole, when when the mitral valve close, you get a little increase, and then there's a stabilization of the pressure, and then you get an A wave, a C wave, and a V wave. Okay, so we're not going to discuss this in detail, but if and if you want us to discuss your different waves, so you have A wave, C wave, V wave, and you have descents, X descent, and Y descent. So we can discuss those in a little bit more detail if you so want a session like that. But you're supposed to know the different components of the Wiggers diagram. You have the phonocardiogram, your ECG, ventricular volume, ventricular pressure, your arterial pressure, or your JVP, or your pulmonary capillary wedge pressure, and then the aortic pressure. So you combine everything, okay? All right, so first we went over this in a little detail. So with the first portion of your diastolic function is your so-called IVRT, which is the isovolumic relaxation time. All the valves are closed, okay? You're actually, well, you finish systole, the aortic valve is closed, but the mitral valve is not yet open. So that's the first portion, or the first part of diastolic function. Then when the mitral valve opens, you get passive, it's like a suction effect, but it's a passive filling. Okay, it's like a suction effect though. The blood actually rushes from the left atrium into left ventricle. So passive early filling of the left ventricle. Then we talk about the diastasis. That is the period between the early passive filling and late filling. It is the equalization of pressure. And then the A velocity, which is the active late filling. Active because the atrium is now contracting, so that's why it's active. So active late filling of the left ventricle due to atrial contraction. And it looks something like this. So this is we're just going to concentrate on the left side. So this is your apical four-chamber view, the mitral valve. Your cursor is right there. The sample volume should be at the tip of the mitral leaflet, okay? Left ventricle, left atrium. And once you press, so this is P Doppler measurements. Once you press your P Doppler, okay, this would be your left ventricular flow track envelope. Then IVRT from the end of your left ventricular flow tract envelope, okay, because you have the aortic valve is closed, and then before the mitral valve opens, so your IVRT, the mitral valve opens, you have your rapid suction, which is the passive filling, okay. So E velocity, diastasis, where there's equalization of pressure, there's no flow. Then your active filling, atrial contraction. And then at the end of diastole, before the aortic valve opens, you have your IVCT. So your IVCT, this is the beginning of systole. Okay, so diastole ends at the A wave. In a normal, healthy individual, the E is larger than the A, but as one age, the E gets shorter and shorter. Okay. All right, so in actuality, this is what it looks like. So your two-dimensional echo is on top, apical four-chamber view, cursor, sample volume, and then your ECG is on top. So in diastole, which is the end of the T wave to the beginning of the QRS, you have your E velocity. This patient actually, so there's a diastasis right there, and then your A velocity, okay? Again, in a normal, healthy individual, the E is larger than the A. Your deceleration time, which is the time from peak E to the baseline, okay? So this is how rapid so you have a rapid, so if you look at your acceleration time, very, very short, so because it's like a suction effect. So the blood rapidly move from the left atrium to the left ventricle, and then it starts slowing off, okay? So this is the deceleration time from the peak E to the baseline. Deceleration time should be less than 250 milliseconds in normal healthy individuals, okay? And then your IVRT, isovolumic relaxation time. So it is usually from the LVOT envelope where it ends to where the E begins. So to get proper IVRT measurements, your sample volume have to be about right here. It has to be between the mitral and the aortic valve. So you're not going to get a good IVRT by if you leave your cursor right there. You have to move it and put it in between the mitral valve and the aortic valve. So about right there. And when you're doing your IVRT, you need to increase your scale so that you can magnify everything, so that when your measurements, your error is going to be reduced. Okay. Again, so the deceleration time is from the peak E to the baseline. Okay. And the computer give you all the readings. So this is the deceleration time, 297 milliseconds, and the pressure half time. So you need to know the relationship between deceleration time and pressure half time. You need to know the relationship between deceleration time and pressure half time, especially for those people who are, well, for everybody, but those people who are doing exams shortly. You know, a lot of time when you're supposed to get deceleration time, they'll probably just give you pressure half time, and then you will be searching around for deceleration time. But there's a relationship between the deceleration time and pressure half time. Okay, the pressure half time is equal to 0.29 times the deceleration time. The pressure half time is equal to 0.29 times the deceleration time. Can you repeat your question? Someone had a question. Can you repeat it? So, okay. Okay, so pressure half time, as the name suggests, pressure half time is the time it takes the pressure in a system to fall to 1/2. Okay? So, you know, so this deceleration time, I would say it is from the deceleration time is from peak to the baseline, whereas pressure half time is not that. Pressure half time is the time it takes the pressure to fall to 1/2. So if you were doing pressure half time from first principles, then you would get the pressure at the peak. Okay, so remember, I don't want to lose the first here, but the pressure at the peak, we talk about a Bernoulli equation, and I don't think we have done that yet with the first year, but the Bernoulli uh, equation states that, or the modified Bernoulli equation states that the pressure gradient is equal to 4v squared, where v is the velocity. Okay? The pressure gradient is equal to 4v squared, where v is the velocity. So we have velocity, right here. Okay? We talk about the e velocity. So we can get a pressure at this velocity, which is equal to 4 times the velocity squared. So we can get a certain pressure right here. So the definition of pressure half time is it's the time it takes for the pressure to fall to 1/2. So we know the pressure here. We can find out the pressure at the half the pressure then. So you can get half the pressure of this peak. So if say the pressure here was 20, So you want to find the time it's going to take for the pressure to fall to 10. So you just convert pressure into velocity, and then you come and say it's right there. And then so 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 you can find the time it takes the pressure to fall to 1/2. We use pressure half time when we assessing the severity of, say, aortic insufficiency, pulmonic regurgitation, and we also use it to calculate valve area when we're looking, say, at the mitral valve. We use pressure half time. We don't use deceleration time. So if they give you deceleration time in those scenarios, you have to convert it to pressure half time. Okay? So in a lot of what we do in echo, we use pressure half time. Okay? So you have to convert your deceleration time into pressure half time. So again, the pressure half time is equal to 0.29 times the deceleration time. So they'll give you a very simple, so in the exam, they will give you something to calculate the mitral valve area, okay? And it's going to be extremely simple. But if you don't know how to convert deceleration time to pressure half time, you'll never get it. So you have to convert your deceleration time to pressure half time. All right, so let's move on. All right, so another important determinant of diastolic function and dysfunction is your tissue Doppler imaging. Tissue Doppler imaging. So what we do, we look at the mitral annular plane, and we just want to see how fast it's moving. Okay, because in health, that mitral annular plane supposed to be moving at a certain speed. Once you have heart muscle disease, then that velocity is going to be affected. More so the diastolic velocity. So remember, when you do tissue Doppler imaging, you look at the medial annulus and the lateral annulus. And you can also, from the medial and lateral annulus, you can develop an average annular velocity. But in systole, the annulus moves up towards the probe, so you'll get an envelope above the baseline. In diastole, it moves away from the probe, so you get a velocity below the baseline, and you get what we call your E prime and your A prime. So the diastolic velocity, you have an early diastolic velocity and a late diastolic velocity. The early diastolic velocity we call the E prime. The late diastolic velocity we call the A prime. Okay, and again, the velocities in the lateral annulus is usually greater than the velocities in the medial annulus, and it's a P-Doppler measurement, pulse wave Doppler measurement. So your apical four-chamber view, this is your transducer right there, cursor is right there. Sample volume is at the medial annulus right here, and you press your tissue Doppler imaging button. Again, ECG is on top, so in systole, the annulus moves up, okay? In systole, it moves up, so you get a certain velocity, okay? In diastole, it moves down at a certain speed, and you get your early diastolic velocity, we call the E prime. Late diastolic velocity, we call the A prime, okay? So if you look closely in it, this is actually your, what we call your IVCT. So don't call this S prime. This first outporting is what we call the IVCT. And if you look at your diastolic component, the first, this little thing right here is your IVRT. So the first diastolic component is your E prime. Okay, so this is tissue Doppler imaging. Velocities in the medial annulus is less than the velocity in the lateral annulus. So your S prime or S wave systolic annulus velocity, E prime is your early diastolic annulus velocity, and A prime is the late. Again, E prime reflects relaxation of the myocardium. It is reduced in patients with impaired relaxation. It's one of the earliest things to be affected, E prime. So decrease in E prime is one of the earliest markers of diastolic dysfunction. So you cannot say someone have diastolic dysfunction with a normal E prime. It just doesn't work. Okay, that's if the patient have diastolic dysfunction, the E prime is going to be reduced. Okay, all right. So these numbers are a little bit, well, these numbers are pretty much the same. But so if you're looking at your medial annulus, the E prime ratio, and this is a very important ratio. Remember, your E is your early diastolic flow across the mitral valve, and E prime is your tissue Doppler diastolic early diastolic velocity. If you get, you're supposed to look at the ratio of your E over E prime. If this ratio is greater than 15, looking at the medial annulus, for the lateral annulus, if you're going to use the lateral annulus, then it's 13. If you're going to use the average E prime, that is, you take the medial and lateral, you divide it by 2, you add them and divide by 2, then it's 14. But for the medial annulus, E prime greater than 15 suggests pulmonary elevated left ventricular filling pressures. Usually the pulmonary capillary wedge pressure is greater than 20. So for those of you who not sure what we're talking about, the left atrial pressure, which is somewhat similar to your left ventricular diastolic pressure, when you develop heart failure, systolic or diastolic, one of the first thing that's going to happen, your filling pressures is going to be increased. That is the left ventricular diastolic pressure and the left atrial pressure. Your pulmonary capillary wedge pressure is a surrogate of that. This is something we do at the bedside. Okay, we put a catheter. We put a catheter, say, through the femoral vein, and then we go up to the right side of the heart. We use a catheter, special catheter, Swan-Ganz catheter, or any type of catheter that can measure pressure. You can use it. So you go up through the femoral vein. You're going to go to the inferior vena cava. Then you go to the right side of the heart. You go through the right atrium, through the tricuspid valve, right ventricle. You're going to enter the pulmonary trunk. You're going to enter the branches of the pulmonary artery, whichever one, and you're going to wedge this catheter. You're going to wedge the catheter in a capillary or a very small blood vessel there. And that pressure that you get is going to be closely related to the left atrial pressure and the left ventricular diastolic pressure. Okay, so at the bedside or in whatever unit you're in, you can measure the capillary wedge pressure, which is a surrogate of the left atrial pressure, left ventricular diastolic pressure. It's not always very accurate, but it's one of the best that we have. Okay, so again, the femoral vein, inferior vena cava, you enter the right atrium, go across the tricuspid valve, the RV, pulmonary trunk, one of the branches of the pulmonary artery, you're going to wedge it. That's what we call pulmonary capillary wedge pressure, that pressure you get. Pulmonary capillary wedge pressure greater than 20 millimeters mercury, it's an elevated pressure. Suggests that the left atrial pressure, the left ventricular diastolic pressure is elevated. This patient is developing heart failure. Okay, so we can in the echo lab we can mimic this, and it's very, very accurate. The EE prime, if you do your EE prime and it's the medial annulus, and if it's greater than 15, it suggests that the pulmonary capillary wedge pressure is greater than 20 millimeters mercury. So you don't have to take the patient to the ICU and put a Swan-Ganz catheter or a PA catheter. You can do your echo at the bedside and get that information. Okay. Similarly, if your EE prime is less than 8, it usually suggests that you have a normal end diastolic pressure. So if the patient has symptoms of heart failure and your EE prime is less than 8, you probably need to look for something else. Okay, all right, because that wedge pressure is not very high, and you can't develop heart failure with a normal wedge pressure. Okay, the definition of heart failure, the wedge pressure is going to be elevated. Okay, so pulmonary vein flow velocity is very important to determine if the patient have diastolic dysfunction. And if you're assessing mitral regurgitation, you need to do pulmonary vein velocity, pulmonary vein flow velocities. So if you remember your apical 4-chamber view, you have one pulmonary vein right there and another right there. Okay, this is your right superior, and there's your left superior is right over there. So yeah, people commonly use this one. So cursor sample volume is right there, and it's a P Doppler measurement. It is a pulse wave Doppler measurement, and you're gonna get your systolic component. So your ECG is on top. You get your systolic component, your diastolic component, and then you get an atrial reversal. You get an atrial reversal component. Okay, and it's in a normal individual. In a normal individual, the systolic component is greater than the diastolic component. Okay, and for diastolic dysfunction, the more severe the diastolic dysfunction, the systolic component is going to get less and less and less, and then your atrial reversal velocity is going to get greater. The duration and velocity will get greater. So if you just step back and look at what happens in the left atrium, your pulmonary veins drain into the left atrium. So in ventricular systole, when the ventricle is contracting, of course, the mitral valve is closed. You still have blood flowing in the pulmonary veins into the left atrium. In diastole, when the mitral valve opens and blood is flowing from the left atrium into the left ventricle, you still have blood flowing into the pulmonary veins and into the left atrium. But when the atrium contracts, so at the end of diastole, when the atrium contracts, then blood is forced backwards. Blood is forced backwards into the pulmonary veins, and that is why you get this atrial reversal. So remember, your transducer is right there. In systole, blood is still flowing, so it's above the baseline. In diastole, you still have blood flowing, so it's above the baseline. Your systolic component, diastolic component. But when the atrium contracts and blood is flowing in the opposite direction, it's moving away from the transducer. So you're going to get atrial reversal below the baseline. Okay. So in the pulmonary vein flow velocities, you have a systolic wave, you have a diastolic wave, atrial flow reversal. As the left atrial pressure increases, the systolic forward flow velocity decrease. All right. So we've been saying over and over that with diastolic dysfunction, diastolic heart failure accounts for approximately 50% of heart failure cases. However, as one age, the proportion or the proportion of heart failure due to diastolic dysfunction increases. Okay, so it's a disease of aging, so to speak. So the grading of diastolic dysfunction can help one to manage patients. Okay, the higher the grade suggests the worsening of the left atrial pressure and left ventricular filling pressures. Okay, so this we're gonna stop here because this is where the new guidelines comes in, and so we have only 3 grading as opposed to 4.